much.
Thank you, Professor Abdelaziz.
Next talk by Dr. Hossam Elsayed. He will talk about modern management of acute type B dissection.
Good morning, everyone. I would like to thank again the organizing committee, Dr. Nasser, Dr. Hossam, for inviting me to present on this subject. So acute aortic dissection is the commonest among acute aortic syndromes, and the incidence is low. It's about 3 in 100,000 person years. Classic teaching is that there are two types of acute aortic dissection, type A and type B. Type B constitutes about 1/3 of the patients. It can be uncomplicated, which is 2/3 of the cases, and the treatment is essentially with optimum medical therapy, or complicated, which is 1/3 of the cases where the surgical intervention is instituted or needed. In the past, it was open surgery. Nowadays, it is TEVAR. Again, the uncomplicated type, we treat them in the ICU with IV medications to lower the blood pressure, control the heart rate and impulse control with pain medication, and look at the CT scan at admission and at discharge, and follow up as an outpatient with optimum medical therapy. The complicated ones are either complicated by rupture or vascular compromise with visceral malperfusion or lower extremity malperfusion, and the treatment is emergency surgery in those cases. And in the past, that was by open surgery in the form of open fenestration with or without aortic replacement or fem-fem bypass. Nowadays, again, it is mostly TEVAR. Two important changes happened since that classic teaching. Number one, the development of the IRAD, which is the International Registry of Acute Aortic Dissection, that looks at the outcomes of type B aortic dissection, and introduction of TEVAR. What does the IRAD tell us? It tells us that aortic remodeling is unlikely with optimum medical therapy, and that about less than half of the patients will achieve the optimum clinical endpoints of a heart rate of less than 60 and blood pressure less than 120 on medical therapy. And over half of the patients will actually develop long-term complications in the form of aneurysmal degeneration that will need intervention. So that led to a paradigm shift in the form of maybe we need to treat all of the patients who present with uncomplicated dissection to prevent those future issues and aneurysmal degeneration. So that led to the INSTEAD trial, which is a randomized trial looking at either treatment with TEVAR and optimum medical therapy versus optimum medical therapy alone, and followed those patients for up to 2 years. And again, these are uncomplicated patients. And then they increased the follow-up up to 5 years. That became the INSTEAD XL trial. And also we got some information from the Vascular Quality Initiative in the United States looking at the treatment of uncomplicated aortic dissection with TEVAR. The INSTEAD trial showed that there is no survival benefit for routine TEVAR for uncomplicated dissection compared to optimum medical therapy alone. But there was improvement in the aortic remodeling over that time. With the extended INSTEAD, again, there was continued aortic remodeling, but the 5-year all-cause mortality was not statistically significantly different. So what does the VQI tell us about treatment of uncomplicated dissection with TEVAR? You can see that the outcomes have significant morbidity and mortality associated with it. So treatment of all patients with uncomplicated dissection using TEVAR has no survival benefit over 5-year of follow-up, and there is significant morbidity and mortality associated with TEVAR for a disease that is deemed uncomplicated. Up to actually 15% will develop stroke, spinal cord injury, and death. So multiple studies ever since looked at high-risk patient factors and anatomic factors that may be associated with the progression of disease. So maybe we don't need to treat everyone, about some patients who will have high-risk characteristics that will lead them to have a progression of the disease. And this is an ongoing research and is essentially a moving target. These are some of the high-risk criteria, which actually affects about half of the patients who are presenting with uncomplicated dissection. Also, the SVS and the STS presented a new classification in an attempt to unify unified consensus on reporting and nomenclature of the classification of type B aortic dissection, and also to increase the attention to the attributes that may be related to long-term results of those cases. So it starts with the anatomic classification, which is type B or A, but added the proximal and distal extent of the dissection. So like here, this is a type B dissection where the tear is zone 2, but it extends from 0 to zone 9, and that's a B09. So that's more descriptive classification for the anatomy. Also, it started to look at the acuity of classification, like uncomplicated, complicated, which is the usual way, but added that high-risk features, concentrating on the patients who are more likely to develop problems down the road. Also, there was a timing classification according to the presentation, where it's hyperacute, acute, subacute, or chronic. So what do we need from TVAR when we're doing acute type B dissection? We need to cover the entry tear to exclude the false lumen and induce its thrombosis. We always have to land in a proximal area that is normal. Distally, we have to cover all fenestrations, and usually that's down to the celiac artery. There should be no oversizing at all, or minimal oversizing of the stent graft. Always use IVUS when we're treating using TVAR, and the highest complication rate is in the hyperacute phase. That's the first 24 hours after acute dissection, and it should be avoided if possible. A word about IVUS, intravascular ultrasound. There should be no TVAR for type B dissection repair without IVUS. It's very important that the IVUS will help us to remain within the true lumen, because if you put a stent in the false lumen, that's usually disastrous. It helps us to evaluate accurately the diameter of the true lumen, where we can decide on which proper size of endograft we should use. It also assists us with evaluating branch vessels and help us to treat them if we need to. So TVAR is enough for uncomplicated cases, but some of the complicated cases, about 10 to 20% of them, will need adjuncts. Those adjuncts might be branch vessel treatment with stenting or fenestration or both, false lumen management, especially in patients who had rupture associated with the type B dissection, where we need to plug or occlude the false lumen, and we had a full lecture about that yesterday. And also true lumen management, where if the true lumen is still compressed even after putting the TVAR, and that using the stent, the dissection stent from Zenith, which is an uncovered stent. We have two ways of doing that, either by just putting it inside the true lumen and help to gradually increase its size, that's the petticoat technique, or forcibly rupturing the septum and to be able to put the stent inside
Is
the
couple of minutes okay?
1 minute.
Okay.
So what's the current status? Optimum medical therapy, again, it's used for all patients, can be the only modality for uncomplicated patients, can be a bridge towards the surgical therapy in uncomplicated with high-risk features, and post-operatively for all cases. Surgical management is used for cases of complicated aortic dissection or after cooling down of the high-risk patients, and for chronic type B dissection with aneurysmal degeneration. So what are the unresolved questions currently? We need to define better the role of TVAR in cases of uncomplicated dissection, optimum time of intervention, what's the optimum extension of TVAR both proximally and distally, what's better to define the role of the petticoat and the stabilized technique, and better defining patients with high-risk features that will most likely develop problems down the road. Also, we have to have a benchmark for morbidity and mortality with TVAR treating uncomplicated dissection. So again, acute type B dissection management is still an evolving science. Currently, we still treat all of the acute dissections with complications emergently. The problem is, who are the ones that we need to select to treat electively early on to prevent them from going into having the chronic complication of aneurysmal degeneration and so forth. Thank you very much.
Thank you.